Hello, my name's Kate Russ and I'm a Quality Lead for the Emergency Medicine Department. We'd like to introduce an audit that we did back in 2013 with a re-audit cycle more recently, and we looked at safer prescribing in the Emergency Medicine Department.
Myself and Lisa carried out a retrospective notes audit in March 2018. We randomly selected 100 patients who were presented to the emergency department between the 1st of December 2017 and the 1st of March 2018. All these patients had been prescribed and administered medications while in the department. They included both adult and paediatric patients. No patients were excluded from the audit and no discrimination was made as to who prescribed and administered the medications, as the prescriptions included were written by medical staff, non-medical prescribers and nursing staff using patient group directives. Prior to the data collection, we identified 5 specific audit standards we wished to measure. The first 4 standards measured were a direct comparison to the standards measured in 2013. Standard 5 was included as specific concerns regarding patient safety were raised in the department. As Lisa had pointed out, the old prescription chart did not include space to document how much of opioids had been given, hence increasing the risk of overdosing or underdosing our patients in the department. The new prescription chart clearly has a box to document this, so we decided to collect the data to determine the effectiveness of the change and therefore review improvements to patient care and safety.
So around 600 people a day attend the emergency department for emergency treatment. Our patient note system is on the form of a Cardex, which is like this. And on the back page is our prescription chart. In 2013, one of our colleagues conducted an audit which looked at the standard of documentation in the emergency department. The results of the documentation demonstrated that our standards were quite poor. The timings of the prescriptions being written and the timing of the drug being administered were not documented in a lot of cases. There's also no space for recording the amount of opioid drug being administered to patients where the drug was titrated to the patient's needs. There's extreme pressures in the emergency department from the high numbers of patients attending, the acuity of patients and the outflow of patients to other areas of the trust. Poor documentation in the 2013 audit demonstrated a risk of drug error occurring. We're currently in a situation where second and third doses of drugs are being administered in the emergency department, and the risk of error is substantial when we don't know what the timing of the first doses are. Additionally, this has an impact on the clinical areas we're transferring patients to when they don't know when the first dose of drug has been given. The risk of opioid overdosage is increased where there's no documented evidence of the previous dose given. In response to these risks, the prescription chart was redesigned. The redesign was done in a consultation between the adult and paediatric areas of the department and between the nursing and medical staff. This was a collaborative approach to patient safety.
So, changes to the prescription chart. The boxes were made bigger to allow legible writing. Signature boxes now require the practitioner to both sign and print to allow traceability. The sequencing of boxes was changed to make clear distinction between the prescribing time and the administering time. There is an addition of a box for a second checker to sign and the addition of a box to document the amount of opioid administration.
We aim to measure both the current standard of documentation in the department and the effectiveness of the redesign of the prescription chart. We analysed 100 sets of patient notes and presented the results as a simple percentage. The 2013 audit results indicate a poor standard of documentation, which can be seen from the table. Having audited practice after the changes to the drug prescription chart, we can see improvement has increased across all the measured standards. The most notable improvement was seen in the timings of both the time of prescribing medication and the timing of administering medication. This was seen as the greatest risk to patient safety. We cannot offer a comparison for opioid prescribing between the 2013 and 2018 audit because it wasn't included in the previous audit. However, in our audit, 85% of notes had recorded the dosage of opioids prescribed. So overall, the improvement in documentation is significantly improved. This has been achieved by targeting changes to the prescription chart to address the problems.
This project addresses a really important aspect of patient care, that of safe prescribing. We work together as a team of doctors, nurses and nurse practitioners across both the adult and the paediatric emergency departments to understand the barriers to safe prescribing. We took a human factors approach to redesign the prescription charts and showed that a simple intervention like this can have long-lasting benefits. Over the last few years, we've become busier, our workforce has grown and become more complex, and we've moved into an entirely new building. Our intervention has stood the test of time, and safe prescribing has now become part of our culture.